Did you know that if you are using the exact same milligram per kilogram dosing for rectal paracetamol as you do for oral paracetamol, then you are probably doing it wrong. For decades, the rectal route has been misunderstood stepchild of pediatric pharmacology. It's been used as a last resort and often burdened with unpredictable absorption. But when used right, it's a total game changer. Stick around because in the next few minutes, we are going to dissect the good, the bad, and the exact BNFC evidence for rectal paracetamol and rectal diclofenac so you never have to second guess a suppository again. My name is Dr. Saeed Kazmi. Welcome to my channel. The biggest myth in pediatric medicine is that the rectal route is just like the oral route, but backwards. Well, physically, yes, but pharmacologically, no. The reason is that the rectum is divided into 3 zones of venous drainage, and where your suppository sits actually determines its fate. For example, if it sits in the territory of the superior rectal vein, then it drains into the portal system, which means that the drug goes straight to the liver for what we call as the first pass metabolism, just like you have it in oral medications. If it sits in the area of middle and inferior rectal veins, then it drains directly into systemic circulation, in which it is bypassing the liver. So the problem that we have now is that we cannot control where a suppository migrates. This is why rectal absorption is notoriously erratic. To compensate for this, our dosing strategy needs to be smart, and more importantly, it needs to be safe. That brings us to the gold standard, the BNFC, or the children's BNF. So what the BNFC actually says about paracetamol. A common mistake on the ward is first calculating the same oral dose strength for rectal dose at a rate of 10 mg per kilogram. Now, rectal doses for paracetamol are higher than oral doses, and they typically sit around 15 mg per kilogram body weight. Now, some people try to calculate a strict 15 mg per kg for a suppository and then awkwardly try to cut a wax bullet, that is a suppository, into half. The BNFC recognizes the pharmacokinetic challenge and the physical limitation of suppository sizes. So instead of strict milligram per kilogram for all ages, the BNFC provides a broad age-banded dosing to accommodate these factors. The BNFC rectal dosing strategy is as follows. For neonates, which are 32 weeks and above, the dose for rectal paracetamol is 30 mg per kg as a single dose, and then 15 mg per kg every 8 hours afterwards. For age 1 to 2 months, is 30 to 60 mg every 8 hours. For up to 11 months, it is 60 to 125 mg every 4 to 6 hours. For 1 to 4 years, it's 125 to 250 mg every 4 to 6 hours. For 5 to 11 years, it's 250 to 500 milligrams every 4 to 6 hours. And for 12 to 17 years, the rectal dose is 500 milligram every 4 to 6 hours. So did you notice the ranges, that is 125 to 250 milligram recommended by BNFC? This allows you to select the nearest whole suppository size like 120, 125, 240 or 250, and that is based on the child's size within that age bracket without underdosing or overdosing. However, it is important to keep the overall track of total paracetamol intake through all the routes, whether it's oral or rectal. The BNFC explicitly warns that if you are switching a child between oral and rectal routes, the total daily dose combined must not exceed the maximum daily allowance to prevent hepatotoxicity. Now let's talk about rectal diclofenac. It's the postoperative powerhouse, and unlike paracetamol, a rectal diclofenac is highly effective for moderate to severe background pain, especially in like states of postoperative or for acute inflammatory flares of various illnesses. However, because it is a NSAID, the BNFC is much stricter on its dosing to protect the kidneys and the gastrointestinal system, especially the stomach. You don't use broad age bands here. You use precise weight-based calculations for rectal diclofenac. So the BNFC evidence for diclofenac is that the indication is pain and inflammation in children over 6 months. In this case, the dose is 0.5 to 1 milligram per kg every 8 to 12 hours. The BNFC is very clear that the maximum total daily dose for diclofenac is 3 milligram per kg of body weight, and in total not to exceed 150 milligrams daily. Yes, do not exceed more than 150 milligrams in a day. Diclofenac suppositories are usually available in 12.5 milligram and 25 milligram strengths. So why it works? Rectal administration provides a steady state of analgesia that is excellent for a child who is nauseated post-anesthesia or post-operatively. It has a significant opioid sparing effect. But wait, there is a caveat here. The BNFC lists strict contraindications. Do not give it to children with active GI bleeding, or those with severe heart failure, or those with a history of hypersensitivity like non-steroidal anti-inflammatory drugs-induced asthma. So let's quickly compare the two medications, rectal diclofenac and rectal paracetamol, through the clinical decision matrix. You can see here that the primary use for rectal diclofenac is that it can be used for mild pain and post-operative inflammation, while paracetamol is used for pyrexia. The minimum age for rectal paracetamol is it can be given in neonates, while for rectal diclofenac it can be given from 6 months onward. The daily dosing rule is that paracetamol is given according to age branded ranges, while diclofenac is given on a strict body weight basis. While frequency, both can be given like 6 hourly, the paracetamol can be given 4 to 6 hourly, while the diclofenac can be given 8 to 12 hourly. But the key limitation is that sometimes it can be unpredictable absorption. It is contraindicated in asthma and renal impairment. So to wrap up all this, number one, never cut a suppository. Now, while clinicians occasionally they can half a suppository in desperation, it is highly discouraged. The active ingredient in the suppository is not perfectly mixed throughout the whole wax base of the suppository. So you might give 100% of the drug if you cut it in half, or even 0% of it. You never know. So use the BNFC age branded ranges to pick up a whole suppository size that fits the child age. Number two, consent is the king here. Always explain the why to the parents and older children. In many age groups, especially adolescents, the rectal route is invasive and is quite distressing. So it should be used when the oral route is compromised, like for example in children who have been persistently vomiting, those who are in an unconscious state, or those who are post-operative. It's not used just for convenience. Number three, track the total dosage. When a child moves, let's say from the ED to the ward, or from nil by mouth back to oral feeds, ensure you calculate the combined 24-hour total of rectal and oral paracetamol so you don't breach the BNFC limits. So fellows, the next time you reach for a suppository to be given in any condition in which you deem it necessary, remember, you aren't just choosing a different entry point, you are basically choosing a completely different pharmacokinetic pathway. So in that particular case, stop guessing the dose and start using the BNFC age brands for paracetamol. And also strictly to the weight-based limits for diclofenac and the dose for physiology. Thanks for watching this. Have a great day. Take care and bye-bye.